guys, so today's vlog is just going to be centered around our appointment at the Houston Fertility Institute. I think it's like decision day of what we're going to do. I mean, I don't really know exactly what's going to happen, but we have that appointment today and I'm going to film it. I don't know how long my footage is going to be, like what we're going to be doing. So if it's really long, then that's all today is going to be about. So, see you soon. Hey guys, this is my doctor, Dr. Abdullah, and he's going to be taking care of us and hopefully helping get us pregnant. Did you want to tell them anything about yourself?
Absolutely. So my name is Mazen Abdullah. I'm an infertility specialist. I practice at Houston Fertility Institute. We have several office locations, and I did my residency and fellowship in infertility at Wayne State University in Detroit, Michigan. Been in practice for 5 years. I moved to Houston a year and a half ago, and I've had several couples have pregnancies over the past 5 years.
It's exciting.
Very good. So we met a couple of weeks ago, and we talked a bit at that time about what's going on. And you've been trying to conceive for almost 2-3 years now. Mm-hmm. Your cycles are irregular, as you told me, and since you started metformin, they became a bit more regular after losing some weight. We said, let's do some workup. You already had your thyroid checked, and I got the records. The numbers are good. Okay. So there's no problem with the thyroid. We checked a few hormones here, and your prolactin is normal, and your one hormone called AMH is elevated, but that's expected with the PCOS.
That's the egg reserve?
That's the egg reserve hormone, correct. So it came back at 6.5. It's not extremely high, but it's actually good. Okay. We usually see it elevated with women with polycystic ovarian syndrome. We had your sperm test already done, and it's normal. And we talked a bit last time that you probably do not have any problems with your tubes. From your history, I didn't see any risk factor for tubal disease. Yeah. And it's reasonable to do treatment without checking tubes. But your tubes are patent, knowing that your HSG was normal. Mm-hmm. You had already 5 cycles of Clomid with timed intercourse, and today I'm going to talk to you about what would we do. Okay. We'll give you some perspective about success rate, complications, and then we'll talk and see what would be our best next step. So typically, I think what's going on in your situation is you're not ovulating on a regular basis, and that's why pregnancy hasn't happened yet. It may happen at any time if you ovulate, mm-hmm. but you probably don't ovulate that often. Yeah, on your own, maybe once a year or maybe twice a year if we're lucky. So having you ovulate is going to be an integral part of our treatment. And to have you ovulate, we're going to do a treatment that involves ovulation induction. What's our best next step? This is something we discuss. So if you look at the efficacy, Clomid probably is not as effective as you'd like it to be after 5 cycles. So, is it an option? It is an option, not necessarily the preferable option at this point. The other 2 are options, but this is my take on the situation as well. If we can do the other 2, I prefer doing either shots with insemination or IVF if we can. If we cannot do them and we have to do treatment with pills, I would change Clomid to something called letrozole. I should tell you, letrozole is we're going to use in off-label use. So Clomid is FDA approved for what we're doing. Letrozole is not FDA approved. Okay. But we've used it for a long time. We have a good experience with it. It came about in 2003, so we have more than 10 years experience with it now. And studies have proven its efficacy and safety.
Is that the Femara?
It's the Femara.
Other name for, okay.
It's the Femara is the brand. Generic name is letrozole. Now we have both brands and generic, so it makes the medication less expensive. Yeah. I mean, it should be a matter of a few dollars to get a few pills that we want, compared to like several $100 only 3 years ago, and it was still under protected by a patent. So you only can get the Femara pill. Yeah. So we have a recent study that has been performed in several fertility clinics all across the country. They collaborated on performing this multi-center randomized trial comparing Clomid to Femara. It was blinded, that is, neither the physician nor the patient knew what their patient was taking. She was taking a pill, and they had a certain protocol to do it. And when they analyzed the data after 5 months of testing, of treatment, they found that letrozole is superior to Clomid in women with PCOS.
Oh, wow.
Okay? I would not know how would you fare on Femara unless we try it. But you've tried Clomid for 5 months, and if we want to go by the book, we probably are better off moving forward. But if you want to spend a couple of months on Femara, we could consider that as well.
I think do you still feel the same?
Yeah, I mean, we kind of talked about this before, and I don't think the chance with the pills is going to be enough to justify.
Yeah, just the pill. No, not just. But we want to do Femara and IUI like once or twice because we're gonna have to pay for it. Our insurance doesn't cover it. So, you think that if I'm not ovulating, that it could happen that way with Femara and IUI?
So Femara, we have a good chance of ovulating on Femara.
Okay.
If we ovulate on Clomid, and then it may help changing the medication a bit.
Yeah.
IUI is going to give us definitely a push in getting pregnant. The chances are still at 8%, but if you get pregnant, it's 100% pregnancy. It's not. So 1 out of almost 11 or 12 women will get pregnant per month on these treatments.
Okay. If it was a Femara IUI, would there be an injection or
there is
like
one shot.
trigger shot?
Yeah, one trigger shot right before insemination to help you ovulate.
And afterwards, would I get progesterone?
It's all dependent on what's going on, how much we've used, how many follicles you have.
Okay.
And whether we find that progesterone is going to be of any benefit at that point.
Okay, because my biggest worry is I start spotting so early in my cycle. I really worry that I have low progesterone or something.
And this would help us decide towards progesterone supplementation.
Okay,
typically, we start a few days after the insemination and continue until your pregnancy test. If it's positive, we support through the first 8 weeks of the pregnancy, and then we wean you off progesterone. By that time, your body is producing enough just to support the pregnancy.
Okay. So I think we want to try at least one IUI with the Femara.
Sure.
Just whenever, I don't know how that works, or as soon as we can.
Your last menstrual cycle was on?
I actually just started spotting today.
So if you get a through cycle, we call day 1 when you start to see the flow.
Okay.
And we start Femara on day 5.
So that's what you guys consider cycle day 1? Because I've had 3 different doctors. It's so confusing because some say any sign of bleeding, and I always thought it was a flow.
It is confusing. We go with a flow.
Okay, good.
Now, if you spot for a lot of days, we gotta look for day 1 of flow. If you spot today and start flow tomorrow, it's pretty much a mental exercise, whether today or tomorrow.
Yeah.
But just to reassure you in your situation, I can call day 1 anytime I want, because your ovaries, the hormone status for your ovaries, as if it's day 1 every day. Okay. They're sort of locked in this phase where we're about to start growing, but they're not.
Okay.
So I don't need to verify day 1 with you.
Okay.
We just wait for day 1. Whether we start on day 4 or day 5 for a cycle, it's not a big deal.
Okay.
Okay? When you used Clomid in the past, you used 50 milligrams twice, and then 100.
And then 100.
And 150. But you got your cycles after
yeah.
the 50, the 100, and the 150.
Yeah, I always got my cycle.
So you probably have responded to all doses. So you can use Femara at 5 milligrams, which is 2 pills. This in the middle.
Okay.
And for 5 days, we do ultrasound 2 or 3 days after the last pill. We see where you are and take it from there.
Okay. Okay, so nope, I don't have to worry about any baseline or anything like
we do a baseline.
We do? Okay.
It's part of the treatment cycle. From expense point of view, if you did 1 ultrasound or 4, it's going to be all built in this expense. We don't charge you per occurrence.
Okay. And so when, is baseline, is that cycle day 3 or so I would come in cycle day 3? Okay.
Sometime this week, looks like.
Yeah, I think so. So, okay. And then I'll just start up. So this cycle, we're going to do it.
Yeah.
That's exciting.
Very. And hopefully it works out?
Yeah. If not, I think then we'll just go straight into the Like if I don't ovulate well and stuff, then we'll just go straight into the injections.
Sure, we'll take it step by step.
Yeah.
Yep.
We'll cross that bridge once we get to it.
Yeah,
Alright?
definitely.
So we
Stay positive about this one.
our objective is to get pregnant,
Mm-hmm.
and if not, then we'll at that point consider our options.
Right.
Okay. Great.
Any other question?
You think of anything?
Just out of my own curiosity, when you were discussing the twins, the rate of twins, is the reason that the pills and the shots
Are different.
is higher than, you know, with IVF with one embryo? Is that because the shots and the pills kind of stimulate multiple
Correct.
eggs? Okay.
Correct.
I was just curious.
So that's one reason we want to do ultrasound as well. Because let's say we took certain treatment and then we're doing ultrasound, and then the day off, you want to take your trigger. If you had 6 or 7 larger follicles that may release an egg, we're going to be having a conversation that day.
Yeah.
But about canceling, because
Yeah, I want to be octomom.
you will not be in that situation because we'll be monitoring as we go, and we
Okay.
fine tune our medication
Okay.
administration according to just these 1 or 2 to actually grow and release the eggs. Sometimes 3. I mean, in your age group, 1, 2, or 3 is our comfort zone. Anything more than 4 is uncomfortable. You're young. We just need you to ovulate,
Yeah.
and then from there on, it's pretty much depend on your egg quality, and we expect very good egg quality in your age group. You're really young.
Okay. I feel like old, so that makes me feel better.
I understand, but like
Yeah.
fertility
Fertility-wise?
wise, we know peak fertility is at age 29. You're only a year or 2 from.
Okay, great.
It's not. You've been waiting, and my job is to help you. I'm gonna help you in the most efficient and safest way.
Yeah. But 30 is a perfectly fine age for fertility usually.
Yep.
Okay.
In your situation, your ovaries are loaded with eggs.
Okay, great.
The condition that you have is your eggs are not being released because of the number of eggs you have.
Okay.
So we just need to help them release.
Okay. And lastly, I just think if for some weird reason I spot a few days and then flow starts, you guys aren't open on the weekend, what would happen baseline-wise?
We can do it on a Friday or a Monday, either day 2 or days 4. It's not a problem.
Okay, alright, cool. I think that's, do you have any questions?
On the weekends, we'll do what need to be done. We'll do, if you're doing an insemination, we'll do it. If we have to do an ultrasound to determine treatment, we'll do it. But things that we can defer to a weekday, we have more resources to do them on weekdays. So on weekday, you come here to do it. On weekend, you have to go down to our main office
Okay.
because the physician is only there.
So if, like the IUI, do you do it?
I do it if
Okay.
we have here, if
Mhm.
we have a person to prepare the sample,
Okay.
and I'm here. Or if we don't have a person to prepare the sample, we have to go to the main office, and if I'm there, I'll do it.
And they're open on the weekend all the time?
We'll open
Oh, that's great.
all the time.
Because my friend missed her IUI because her place wasn't open on the weekend.
It's pretty much place dependent. In a busy practice, you cannot close and say, "Oh, we're taking Sunday off," because
Yeah.
you can plan whatever you want. Some ovaries are gonna ovulate on a
Yeah.
Sunday, and
That's great, that makes me feel a
it's
lot better.
easier to actually be open every day than try to
Yeah,
work around a certain day you want to close.
Great.
And we have 10 physicians in the practice, so one of us is always available on the weekend. Sometimes 2, depends on the patient load. It may not be myself doing it on the weekend, but I mean, I have confidence in my physician colleagues, and I do some of their patients as well on the weekends in my lab, so
Great.
Excited?
Me too, we're excited.
very good. We get it started this month, okay?
Okay guys, we're back home and I don't know how much I'm actually going to edit of my appointment. So I just kind of wanted to do a, I don't know, like a brief summary. Sorry. Cycle day 3, which I have a feeling Aunt Flo is coming tonight or tomorrow. Cycle day 3 will be, I will go in for baseline stuff, and then if that's all good, then cycle day 5 I'll start Femara, and then whenever it's time we'll get a trigger shot and an IUI and progesterone if needed. So it is going to be this cycle. I'm like excited. And let's see what else. They took a bunch of blood work after we left the room, but I can't film that side of it because my doctor's office is not it's like a separate company that does the blood work, and they said that they don't allow that or pictures or anything like that. So Yeah, I mean, I could call their corporate, but I'm pretty sure they're going to give me the same answer. So, let's see. Yeah, and then we just went to the grocery store, and I didn't do a grocery store haul or anything because I got, like, not, like, terribly unhealthy food or anything like that, but a lot of frozen stuff and a lot of frozen vegetables because every time I do fertility drugs, I have, like, hormonal headaches. I'm, like, nauseous and a bunch of other stuff. So, hopefully that won't happen this time, but in case it does, I want to have, like, groceries that are, so we're not eating out, but that are fast and easy. So it was nothing great about the groceries I bought. Probably after this IUI and all that and everything calms down, then I'll start doing grocery store hauls and stuff again. But I also got a question from Ditzy Chick, and it's one of the people that I can't answer usually because of YouTube being stupid, but I couldn't reply to you. But your question was about, would we be able to film our adopted or foster kids, like, does CPS allow that? I actually don't know. I doubt it unless they are adopted and ours, but my plans are to either blur their face, and when I learn how to do that, and in my editor, I can try that. Or my other plans are to film things of them, but the back of their head. So if we're doing something fun, it would be kind of like whatever they're doing from behind, or just not showing their face would be the thing I focused on. And then once we adopt them, I mean, I could be totally wrong. I mean, it could be allowed. I'm just going to have to talk to the social workers about that, and we're still waiting a call from them, but it takes a while once your packet goes in to start getting calls and all that stuff. So it's a waiting game, but I hope that answered your question. And so I'm going to wrap this vlog up because it's probably going to be a long one today, and I'm sorry, but I wanted to share the whole experience with you guys, and we'll see you tomorrow. Bye.